MI-CBT Part 2. We pick up with the process of focusing. Focusing is of central importance to CBT. During focusing, the practitioner helps the client understand the nature and extent of their emotional and behavioral difficulties, often providing psychoeducation, and moves towards a shared commitment to a treatment goal or goals. Focusing, identifying a change goal. Agenda setting, readiness scaling, decisional balance, information, and advice. Sometimes this is a very straightforward process. For example, when the client is seeing you at a dedicated center for anxiety disorders. Clearly, we're going to be talking about anxiety disorders. And sometimes this is a much less straightforward process. Clients may come in with multiple vague concerns. Their priorities may differ from those of the practitioner. They may have strong beliefs about what will work to relieve distress, and also whether or not they have the capability to do their part. The tools listed on this slide are helpful starting points for effective focusing conversations, especially in these much less straightforward situations. Agenda setting is a helpful way to structure early conversations. We could talk about drinking, working, getting your kids back, or housing. Where would you like to start? So forth and so on. This is an agenda setting chart completed either before a meeting with the practitioner or in the first few minutes of the conversation. The targets here are potential concerns of somebody seeking help in weight management or perhaps in a diabetes clinic. Take a few minutes and draft an agenda setting chart for your clinic or one that might be helpful for a new client in an anxiety disorders clinic. Take a few moments at the end of the lecture and develop your own agenda setting chart. In addition to agenda setting, scaling is another task of great value. Although scaling has ties to each of the four processes, I like to discuss it in the context of focusing because this is where it first is of relevance in MI-CBT. Early on in the CBT intervention, one needs to address three universal client concerns. How important is this change for me? i.e., is my fear of heights really interfering with my day-to-day life? How credible is the proposed treatment? Do I truly believe that pushing myself into feared situations will help me overcome my fear of heights? And how confident am I that I can start the process and stick with it? Importance of change, credibility of treatment options, and confidence in being able to initiate and stick with the intervention I choose. In motivational interviewing, we use scaling to better identify the client's level of readiness to change by addressing these three fundamental dimensions of readiness. Why should I? How can I? And how much do I believe you? We do this in a manner that supports both the relational and the technical sides of MI by both communicating curiosity regarding and acceptance of the patient's perspective, and by also asking questions that are designed to elicit change talk. There are three questions for each component of the importance, confidence, credibility, scaling. First, we obtain a number reflecting current status regarding importance, confidence, or credibility. Second, we ask the downward question. which communicates both acceptance of the patient's readiness state and also elicits change talk by asking the client to utter words of problem identification and concern. Why is it a 6 and not a 4, for example? Third, we ask the upwards question, a more confrontative question, which invites discussion of the parameters of concern. What would it take? What would have to happen to raise your confidence score up a point or so? The result, which is a rating in a context, usually provides the practitioner with an understanding of the ways in which the patient thinks about the target behavior. In other words, this inquiry allows the practitioner to get into the client's world, to appreciate the targeted behavior change conversation from the point of view of the client. The same 3 questions are asked with regard to confidence, yielding a wealth of data regarding general readiness, the context in which the patient considers change, and whether one needs to focus on exploring importance or building confidence to facilitate the engendering of motivation for and commitment to change. We also ask these same 3 questions with regard to credibility, again, adding value to our understanding and appreciation of the various parameters of the client's approach in thinking about change. This importance confidence matrix can guide the practitioner forward, juxtaposing the importance and confidence credibility ratings. One decides how best to proceed. Low importance, low confidence, credibility, the individual is clearly not ready to move forward. High importance, low confidence, low credibility, the target is now exploring the hows of change. High confidence, low importance, the problem is the whys, and when everything is high, confidence, credibility, and importance, go ahead with great gusto. As mentioned earlier, after obtaining the initial scaling number, how confident are you? We ask the downward question next. This is important because it invites the client to explore change in a non-confrontative, low-pressure manner. The discussion that follows the importance confidence scaling intervention often serves as a transition into the action phase of the healthcare consultation or of CBT, wherein one informs, advises, and educates the client. The challenge here is to maintain rapport during a more directive part of the consultation. As you know, informing is a key component of CBT and occurs in every session. In the context of engaging, one informs the client of one's treatment orientation, creating the groundwork for CBT. During focusing, one usually gives the client feedback, presents a clinical formulation, dispels misinformation, and provides psychoeducation. Once CBT is underway, informing presents in all phases of treatment implementation, including exposure protocol development, cognitive correction, reviewing of homework, behavioral contracting, etc. Therefore, learning how to do this well, to educate without wrestling, to share information collaboratively, is a key component of effective MI-CBT. Good educators accomplish 2 tasks. Effective health educators must both provide solid information and also maintain rapport. If rapport is undermined, ears close and the opportunity for influence through information goes away. One must maintain rapport and the client's eagerness to engage with you during education and information exchange. How can one maintain rapport? Ask permission before informing, advising, or giving feedback. For example, do you mind if I discuss with you some options for managing hypertension? Can I give you a bit of advice? There is a large literature in social psychology supporting the role of permission giving in processes of persuasion and interpersonal influence. Suffice it to say that this simple strategy is an exceptionally powerful way to sustain collaboration between client and practitioner. Having asked permission, we move into collaborative information exchange, collaborative education, something we've called ask, tell, ask, or elicit, provide, elicit. Ask, tell, ask serves as a structure for information exchange in MI-CBT. Having asked permission, we then elicit the client's ideas, questions, and concerns regarding the topic of discussion, thereby setting a patient-centered agenda. This is followed by a brief, jargon-free delivery of information, the tell, and then a return to the client for further input. Ask, tell, ask, elicit, provide, elicit. Here are some effective eliciting questions for setting the agenda, for setting the stage of psychoeducation or information exchange. What do you know about cholesterol? What has your mom, grandmother, friends told you? What have been your experiences with desire, with diet and exercise? What are your concerns? So forth and so on. Here's a bit of dialogue between an infectious disease doc and her very sick patient. This patient is chronically homeless, positive for the HIV virus, and a long-term IV drug user. He presented at clinic complaining of a high fever and acute pain, all of which were consistent with serious disease. What are the benefits of asking the patient, have you ever heard about endocarditis? What does the doctor do by doing that? What does she learn? What does she avoid having to do? What does she set the stage for? He's heard of endocarditis, although he's never had it before. So he's probably witnessed somebody he knows go through endocarditis. Endocarditis, if not treated rapidly, often ends with death. Perhaps this image, this idea, this perception, this understanding of endocarditis increases his willingness to go across the hall and sit in the emergency department for 3 or 4 hours awaiting admission. By asking him what he knows about endocarditis, she avoids redundancy, telling him things he already knows. Nobody wants to hear things they already know. This is so important that it's accompanied by a behavioral cue. When teaching or advising, when psychoeducating, first elicit the client's ideas with open questions. Ask, tell, ask. Elicit, provide, elicit. When telling, when providing information, when informing the client, we try to stick with words that support collaboration and choice. Third-person language trumps I think and you should utterances. Rather than saying I recommend, indicate that scientists have found, researchers suggest, practitioners advise, etc., etc. By doing this and using wiggle words, words that allow choice, options, that empower the client, The client is left with choice and control, and this facilitates the acceptance of the practitioner-delivered information and advice, and also supports shared decision-making and collaboration. Nobody likes to be talked down to. Nobody likes to be told what to do. Some patients are particularly concerned about the loss of power and control. Informing with wiggle words is very helpful in this regard. Also, keep your message simple. Less is more. When in doubt, leave it out. Ask, tell, ask. We've elicited the client's input. Follow that with a bit of non-jargon, wiggly word information, and then we go back to the second ask. Following information delivery, the practitioner asks the client again, eliciting further input and perhaps intention to change. The nature of this second ask will vary with the phase of treatment. During engaging, the ask will focus on motivation to change. During planning, the ask will more likely focus on negotiating a specific change plan. In any event, it is this back and forth nature of information exchange that is key to effective MI-CBT. Engaging, focusing, informing. Now we move to evoking. With the relational infrastructure of engaging and focusing in place, the practitioner can focus on the evoking process of MI, the eliciting and reinforcing of change talk. So far, we have talked a lot about the importance of eliciting input from the client. Evoking is really a subtype of the more general eliciting process, whereas eliciting refers to any attempts to invite the client's input. For example, have you ever heard of endocarditis? Evoking refers to the specific task of eliciting and reinforcing change talk. The technical component of MI, operationalized through evoking, interfaces with the philosophy of language with regard to the way that language communicates intentionality. Change talk and sustained talk are the labels for positively and negatively valenced utterances of intentionality, respectively. They're simply two sides of the same coin. Psycholinguists have parsed change talk into a variety of subcategories. These categories, desirability, reasons, and need, capture intentional utterances that are relatively distal to behavior changes, utterances that reflect motivation to change. We call these preparatory change talk. Desire, I want, I wish, ability, I can do it. Reasons, if I do it, then this will happen. Need, which is really desire with passion. Mobilizing change talk is more proximal, closer to change, and therefore of particular importance in the recognition and appreciation of client intentionality, of client's intention to change. Commitment, activation, and taking steps. Commitment, I hereby give you my word. Activation, which is really a weak commitment. I think I'm ready. I'm willing to consider. And taking steps, I've done things. I went home and walked to the mailbox and back, etc., etc. So here's how MI works. The practitioner engages the patient in a manner that invites change talk through engaging, focusing, and evoking. This usually first results in preparatory talk, the whys and hows of change, desirability, reasons, and need. Preparatory talk is of most significance as a precursor to mobilization talk. Mobilization talk, the what and when of change, firmly predicts behavior change. So we try to set the stage for preparatory talk, which then sets the stage for mobilization talk, otherwise known as implementation intentions, which is the best predictor we have of behavior change. Sustained talk is simply the flip side of the intentionality coin. And we often hear preparatory sustained talk as well as mobilization sustained talk. Sustained talk, especially intention to sustain current behavior, predicts behavior consistent with these speech acts. Change talk predicts behavior change. Sustained talk predicts commitment to the status quo. Change talk and sustained talk are simply opposite sides of the same linguistic coin. I really like my weed desire. I couldn't possibly give it up, ability. I have to smoke to be creative, reasons. I don't think I need to quit, need. I'm planning to continue to use, commitment. I'm not willing to quit, ability. I bought some weed today at the local dispensary, taking steps. So what do we do, having identified change talk and sustained talk? How do we operationalize evoking? How do we operationalize this technical component of MI? In this regard, there are three basic strategies of evoking. First, before anything else can occur, one must minimize sustained talk by avoiding getting into wrestling matches with clients and otherwise avoiding the elicitation of that side of the argument. Do no harm. Second, the practitioner needs to recognize and reinforce naturally occurring unsolicited change talk. Third, the practitioner can actively elicit change talk through the use of a number of structured techniques and strategies. Change talk sandwich. Recognizing change talk is more difficult than it might seem. Change talk is hardly ever delivered to us on a silver platter. It's usually sandwiched in among sustained talk. For example, a plump child is a happy child. I know I need to give him healthier snacks. It's just that I'm so busy I can't imagine where I'll find the time to shop. The change talk utterance, I know I need to give him healthier snacks, is the diamond in the rough. It needs to be recognized and reinforced by the practitioner. How do we do that? You use your ears. Once recognized, the practitioner can respond with his or her ears. Ask for elaboration. Tell me more about your concerns about unhealthy snacks. Affirm effort and intent. You really are concerned about your child's health and willing to do whatever it takes. We respond with a reflective statement. You realize that you need to up your game in terms of the healthy snacks. Or respond with a series of reflections that summarize preparatory and activation talk. Respond to change talk using your ears. Now we move on to the fourth process of MI, planning, moving into action. Planning is a very broad process. In MI-CBT, planning most specifically refers to the transition into the structured treatment. However, the planning process is also invoked at the end of every session when homework is discussed, at times of treatment difficulty, and at all transitional points in treatment. For example, when moving from the cognitive to the behavioral components of CBT for insomnia. Planning builds upon the relational foundation and utilizes the ask, tell, ask information exchange structure here in the service of shared decision-making and the commitment to the initiation of a specific intervention. When moving into planning, always start with ask, tell, ask. When using ask, tell, ask to negotiate an action plan, additionally, always provide a menu of options, treatment options, of intervention options, of ways to go. Clients who self-select an option for change are much more likely to remain committed to the plan. Offering a menu of options also supports client autonomy and empowerment. Populate this menu of options with action steps that are consistent with the client's current readiness to change. Small, well-planned steps are often the way to go, especially when the client may be skeptical about the treatment you're offering, especially when the client has a low credibility rating with regard to your evidence-based treatment. In this picture, we have a mouse that's practicing harm reduction. He's not yet willing to give up the cheese. However, he is willing to wear a helmet. Negotiation and planning need to be followed by the elicitation of a clear commitment to change. We need to have mobilization talk. Mobilization talk, otherwise known as implementation intentions, are the best predictors of subsequent change. This gentleman is not ready to take the leap. However, he is ready to take the hop. Here are some pointers for effective planning. Ask permission first. Invite the client's input. Less is more. Keep your message simple. Use wiggle words. Use third-person language. Insert reflections and affirmations into your psychoeducation. And above all, remember, when in doubt, leave it out. The MI-CBT Sandwich. As we move towards the end of this lecture, we must talk about where a bit of MI fits in to CBT. MI-CBT serves to integrate the relational and technical features of MI with the targeted evidence-based interventions of CBT. In MI-CBT, we are looking for small ways to sandwich in a bit of MI into behavior change consultations. Here are some sandwich pointers. You find yourself arguing, finger waving, jumping up and down, or cheerleading, you're likely falling into the writing reflex. So don't argue, finger wave, or overly cheer on the client. Ask permission first before advising, informing, collecting information, evaluating, assessing, or otherwise moving into a directing role. Ask fewer questions. Turn your questions into reflections. Oftentimes we ask questions that are irrelevant. Oftentimes we ask questions for which we already can presume answers. A complex reflection will go further towards engaging the client in conversation and collecting information than will a question. Roll with resistance, dance with discordance. Cakewalk with low confidence. If you're falling into a wrestling match with a client, stop what you're doing, fall back into effective reflective listening to demonstrate a neutral understanding of the client's point of view. Empower the client. Collaboration is all about power sharing. Emphasize the fact that the client is the decision maker. The client will be the person doing all the work. Watch your language. offer a menu of options, say less rather than more, and make sure that your treatment intervention, the goals of your intervention, are focused, that they match the patient's readiness, that they coordinate with the patient's sense of importance and confidence. So before you finish this lecture and move on, take a moment to review the various strategies of MI that have been discussed and identify the ways one might weave in a bit of MI into CBT. Use the 4 processes model to structure your thinking. At this point, we will end part 2 of the MI-CBT lecture.